Thank you again. I'm going to try to use the same format that we did before to try to keep everybody awake. What is constipation? The stool frequency of less than 3 times per week. Too infrequent, too little, too hard. Remember that. And also, important to remember that you have the lack of urgency to defecate. Sometimes, however, we see straining at defecation or a sense of incomplete evacuation and the use of the finger for stimulation of the rectum to complete the evacuation. So all of these elements somehow together or sometimes in isolation from each other define constipation. So it's not only the frequency but also possibly the lack of urgency and also the inability to have a complete evacuation and sometimes the need for using digital maneuvers. There are several rules that I would like to present to you. Number one rule is to exclude mechanical obstruction, something that's blocking the distal bowel usually, and that usually is exposed or detected by colonoscopy or sigmoidoscopy. Usually a sigmoidoscopy could actually do that because we're talking about the distal bowel. The alarm symptoms are the occurrence in somebody who's over 45 years of age, rectal bleeding, weight loss, or a family history of colon cancer or inflammatory bowel disease. If that patient has elements in the history of these predisposing states, number one rule is to exclude mechanical obstruction. Obviously, a rectal examination is very important, and it should not be bypassed because it may reveal all kinds of interesting surprises. What you see here is extreme degrees of rectal prolapse or hemorrhoidal prolapse, etc. Sometimes it's much less prominent, but it's important to be included in the examination. That rectal examination also will allow you to identify the mobility of the pelvic floor and the coordination of the rectum to the anal canal. And knowing and practicing a rectal examination in patients is very important. It will help you a lot decide about what you're going to do next with a patient who has presenting features of constipation. Colonoscopy is an important tool. You've heard a fair amount of information from Dr. Saunders a few minutes ago about the value in colorectal cancer screening, and obviously the colonoscopy will help you identify other conditions that may be associated with constipation, such as diverticulosis or even hemorrhoids. Sometimes we pick up solitary rectal ulcers, another kind of pathology that would explain the constipation. As we look at the differential diagnosis, we have to consider functional causes of constipation versus secondary causes of constipation. And it's important to exclude these possibilities. For example, there's drug-induced constipation, so reviewing the drugs that the particular patient is using is very useful. Calcium channel blockers are the number one in my practice, for example. We have to look for neurologic conditions that may predispose the patient to secondary constipation. We have to think about metabolic causes for constipation, and obviously mechanical obstruction, as we covered a minute ago. So number two rule is to exclude secondary causes of constipation. This is a 56-year-old man who has a history of Parkinson's disease who presented with difficulty breathing and constipation. And a CT scan was performed, and you can see here, this is a lateral CT and shows a severely distended colon with fecal material all throughout. The colonic lumen has been doubled in terms of its size. There was no colonic perforation. The patient was manually disimpacted and was given multiple sodium phosphate enemas and then was placed on long-term osmotic laxatives plus linaclotide, which is an agent that we use for constipation, for relief. In terms of other drugs that we mentioned earlier about drugs, anticholinergics, quite commonly used, antispasmodics, antidepressants, antipsychotics, cation-containing agents, iron supplements, neurally active agents, and particularly opiates, patients who use opiates for pain control, as well as others, such as calcium channel blockers, antihypertensive agents, etc. So again, reviewing the list of medicines that the patient is on is absolutely critical. Number 3 rule is to distinguish constipation from irritable bowel syndrome, which sometimes can be subtle. And there are criteria that we use listed here: straining more than 25% of defecation, lumpy or hard stool in more than 25% of defecation, a sensation of incomplete evacuation, a sensation of anorectal obstruction, manual maneuvers to facilitate emptying, and less than 3 defecations per week. All of that would actually define constipation over irritable bowel syndrome, which is usually associated with recurrent abdominal pain, improvement with defecation, onset associated with a change in the frequency of stool, and onset associated with change in the form of the stool. And all of that is more of a semantic thing, but I guess it helps you define the magnitude and the severity of the constipation, which tends to be more severe in the non-irritable bowel syndrome cases. And finally, to assess the type of constipation, and you have to define it in 2 or 3 actually categories. One is something that we call slow transit constipation, or otherwise called colonic inertia. And the other entity, which is called pelvic floor dyssynergia or outlet obstruction. And sometimes we see a mix of the two, but the treatment is kind of different in those 2 entities of functional constipation, and differentiating the particular nature of the constipation helps us with our management. In the terms of management, we have to really use tools to diagnose the condition and classify it accordingly. So we have different tools. One is called colonic transit, that can be done either by a Sitzmarks method, which is a very simple radiology-driven test that the patient swallows a capsule and then an X-ray is taken, or a very fancy test called the smart pill test that allows you to measure exactly the time of colonic transit. And then there's anorectal motility test, and there is also a fancy radiographic test that can be done either by conventional X-ray or by MRI that allows you to study the performance of the pelvic floor and define for the possible pelvic floor dyssynergia. And I would like to show you these kinds of studies a little bit more detailed. The Sitzmarks study, you swallow a capsule that contains these small rings, and then 5 days later you have an X-ray of the abdomen, and if those rings are still in the patient's abdomen and projecting on the X-ray, you can actually call this colonic inertia. The smart pill technology, the patient swallows that pill, which then utilizes the temperature, pH, and pressure to define its presence within the stomach, small bowel, or the colon. And through that technology, you can actually quantify the colonic transit time. Anorectal motility study can be done with a very easy equipment that is inserted in the patient's rectum and can actually define the pressures, and you can generate those computerized tracings of how the opening and the closing of the anal canal and its coordination with the rectum. There is MR defecography, which is a fancy way of doing defecography, the traditional method being barium, that you can actually assess the anorectal angle and the descent of the pelvic floor in the context of an actual process of defecation that happens at the time of the scan. And that gives you an appreciation of the level of dysfunction at the level of the anorectal junction. So I will take you through some cases to just highlight some of the main issues that we just talked about. We'll start with a 42-year-old woman with a 20-year history of constipation. She has 1 to 2 bowel movements per week, mostly consisting of hard stool. She has to strain when she has to have a bowel movement. She has no blood in the stool, no abdominal pain, no weight loss, no diarrhea. She's otherwise healthy, and she occasionally uses laxative and stool softeners. On examination, her vital signs are normal. Anorectal tone is normal. She's able to expel the examiner's finger when asked to mimic a bowel movement. She has normal laboratory studies, and a radio-opaque study, the Sitzmarks study that I showed you earlier, shows delayed transit time with all these markers accumulating along the outline of the colon. Which of the following is the most likely diagnosis? Chronic intestinal pseudo-obstruction, constipation predominant irritable bowel syndrome, pelvic floor dysfunction, or colonic inertia, or so-called slow transit constipation? The answer is colonic inertia. There is a medication called Linaclotide, which is very valuable for this condition. It's a minimally absorbed peptide agonist of the guanylate cyclase C receptor. It stimulates intestinal fluid secretion and transit time, and it's approved for chronic idiopathic constipation at a dose of 145 micrograms per day. As a side effect, it's diarrhea, which is mostly welcomed by the patient, but sometimes it's excessive and it bothers them as well. Here's the data published a few years back in the New England Journal of Medicine, 2 different trials that you can see that compared in the low dose of 145 versus 290 micrograms per day, you have improvement over placebo, which is quite significant. And this is an evolutionary curve that shows you that during the treatment period and then when the period is stopped, that you can see the difference over placebo with the 2 doses of linaclotide versus placebo. Another drug is Procalupride, which also has been used in the management of constipation. This is a 5-HT4 agonist, and you can see again at 2 different doses, 2 and 4 milligrams, a significant improvement over placebo, particularly again for patients with slow transit constipation. Another approach to consider for severe cases, and I actually see about probably 2 to 3 patients a year in my practice who do not respond to any medication, but they have severe colonic inertia. These patients may respond very nicely to subtotal colectomy with an ileo-rectal anastomosis shown here. This can be done laparoscopically with a very small, tiny scar on the left lower quadrant, and the patient converts the constipation, which is usually at a pace of 1 bowel movement every week or every other week, to about 3 to 5 bowel movements a day, and usually without any fecal incontinence. So that is actually, again, something that is effective. Second case is a 25-year-old woman with a 2-year history of daily bloating and lower abdominal cramping. She has constipation, which is relieved by bowel evacuation and is worse when she's under stress. She has 1 to 2 small bowel movements per week. She feels incompletely evacuated. She has no diarrhea, no blood in the stool, no nocturnal awakenings with pain or for bowel movements, and no weight loss. She has taken a fiber supplement without relief. She's otherwise healthy. She uses an oral contraceptive. Her mother had a similar condition when she was younger, but both her parents are alive and well. Physical examination vitals are normal. She has mild lower abdominal tenderness, no rebound, no guarding, no palpable abdominal masses. Her hemoglobin is normal. Serum biochemistry tests are normal, including the thyroid stimulating hormone. Which of the following is the most appropriate next step in the management of this patient? Colonoscopy, CT of the abdomen and pelvis, discontinue the oral contraceptive, or reassure the patient and use polyethylene glycol? The answer is to reassure this patient and use polyethylene glycol. This is a typical case of a patient with irritable bowel syndrome. This is a young woman. She meets the Rome-3 criteria that we just discussed, and they have a very good positive predictive value of about 98%. She has no alarm features and no abnormalities on laboratories. So irritable bowel syndrome is a very common cause of constipation. It's a clinical diagnosis, and in most cases it's actually constipation predominant. There's also a form of mixed irritable bowel, but there's also a form of diarrhea predominant irritable bowel. But typically there are no laboratory, radiographic, or endoscopic findings, and additional tests are unnecessary and potentially harmful. The patient should be reassured, and the polyethylene glycol would very, very quickly provide her with significant relief, and it can be adjusted as the patient needs it. Third case is a 34-year-old woman with constipation and straining. She has incomplete evacuation. She has tried multiple laxatives. She uses vaginal digital pressure to evacuate. She has no tenderness to abdominal palpation. Her anal tone is normal at rest, but it increases with the effort to produce an evacuation. This is a very important finding on the rectal examination. Which of the following will be the most useful next step? Colonic transit time, defecography, sigmoidoscopy and biopsies, or treatment with linaclotide? The answer is defecography. And I showed you an example of defecography because it characterizes visually the pelvic floor descent and the coordination between the rectum and the anal canal. And this is an example of a dynamic pelvic MRI that shows a rectocele, which the patient was actually pushing against to reduce the rectocele, shown in the, with the arrow, and facilitating the emptying of the rectum. Colonic transit time is most likely normal. Patients have normal urge to evacuate, but it is troubled by outlet obstruction. The sigmoidoscopy will have a very low yield in a young woman without rectal bleeding, and linaclotide is indicated in patients with colonic inertia and not in patients with pelvic floor dyssynergia. In contrast, anterior rectopexy can be performed, and that actually can fix the problem of the rectocele and correct the pelvic floor emptying and evacuation. The fourth case is a 48-year-old woman with constipation. She has tried multiple laxatives. She's now taking fiber and polyethylene glycol twice a day. She has abdominal cramping and infrequent bowel movements. She has no family history of cancer. She had a normal colonoscopy 6 months ago. She has mild tenderness to palpation in the right and left lower quadrants without peritoneal signs. She has no masses. Her anal tone is normal at rest and with simulated evacuation. Which of the following is the most appropriate treatment? Hyoscyamin, which is an antispasmodic, Lubiprostone, which is another agent for constipation, metoclopramide, or tricyclic antidepressant? And the answer is Lubiprostone. Lubiprostone, or so-called Amitiza in the United States, is a C2 chloride channel activator that causes, similar to the linaclotide, secretion of salt water into the intestine and improves colonic motility. And it is approved particularly for irritable bowel syndrome with constipation, specifically in women, as well as idiopathic chronic constipation in higher doses. So the low dose is approved for irritable bowel syndrome with constipation. The high dose is approved also for idiopathic chronic constipation. The side effect of that medication is that it's causing sometimes nausea, up to 30%, and if it's taken after a meal, it's much less so. It's a pregnancy category C, and it's appropriate for patients whose symptoms persist despite the use of fiber and standard laxatives, particularly in women with irritable bowel syndrome with constipation predominance. And this is the data comparing lubiprostone 24 micrograms twice a day versus placebo, and you see the superiority of this agent in a double-blind fashion. In contrast, hyoscyamin reduces the abdominal discomfort in irritable bowel syndrome, but may worsen the constipation, so that's not going to help this patient. Metoclopramide is a prokinetic that is used for gastroparesis and has no role in the treatment of irritable bowel syndrome. And tricyclic antidepressants are used for the symptomatic management of abdominal pain in patients with IBS, but they may exacerbate constipation. So they can be used, but in conjunction with an agent that would help the constipation. The next case is a 67-year-old man with metastatic pancreatic adenocarcinoma who was admitted for pain control. He takes intravenous morphine, both short-acting as well as time release. He's constipated despite the use of docusate sodium and senna. He's passing gas. He cannot tolerate polyethylene glycol. Fiber causes excessive bloating. He's cachectic. His blood pressure is 115/80. His pulse is 76. Respiratory rate of 14. He has mild tenderness in the upper abdomen, no distension, no guarding or rebound. He has firm stool in the rectal vault, normal laboratory studies, and the abdominal radiograph reveals stool throughout the colon without any air fluid levels. Which of the following is the most appropriate management? Add methylnaltrexone, surgical colostomy, administer a sodium enema, or decrease the morphine dose. Remember, he has metastatic pancreatic cancer. The answer is add methylnaltrexone. And this is otherwise called Relistor, which is an opioid inhibitor. And you can see here the improved management and the improved laxation with different doses of Relistor. Usually, the dose that we usually start with is 12.5 milligrams. And that's used as an injection every other day. The last case is a 30-year-old man who reports 2 weeks of persistent perianal pain that worsens with defecation. He feels severely constipated. He also noticed a small amount of bright red blood on the toilet paper after wiping. He denies abdominal pain or any blood in the toilet bowl. He reports no anal trauma, and physical examination reveals this lesion. Which one of the following approaches is most appropriate for initial management of this patient? I gave you the answer here, but botulinum toxin injection in the anal sphincter is one approach. Mesalamine suppositories in a low-residue diet is another. Surgical referral for sphincterotomy, or topical nitroglycerin, or sitz baths and fiber supplementation. This was an anal fissure case that causes severe degree of constipation. It's associated with it, at least. And the first management step would be to do sitz baths and fiber supplementation, although the other options are also available in case of resistance. Thank you very much for your attention.
Thank you very much. Questions? Professor, how far can a primary care physicians go in terms of prescribing anti-constipation medications? For instance, in Greece, we only have, in terms of novel treatments, only Procalupride. And which are the patients which need to be referred for functional testing, like colonic transit or defecogram?
Actually, I think that the primary care physician could actually handle the whole thing, other than potentially the issue, is there any obstruction or a mechanical obstruction by a cancer? As long as that is secured, everything else can be managed at the primary care level, particularly since the SITS-mark test, which I don't know if it's available in Greece or not, it's a very simple one, very inexpensive one, and can address the issue of slow transit. And if the history is well taken and one can exclude accurately the presence of any kind of pelvic floor dysfunction, then Linaclotide, Lubiprostone, all the other agents that I mentioned could be used by primary care, and I don't think that they should be necessarily confined to gastroenterologists. And I don't think we really need fancy testing. The fancy testing is usually done in the context of evaluating a patient for possible pelvic surgery or abdominal surgery for subtotal colectomy, etc.
Okay, thank you very much.